Hello, my name is Lucy Clarke. I'm the Clinical Lead Occupational Therapist for the East Area Mental Health Occupational Therapy Service of Betsy Cadwallader University Health Board.
And I'm Kim Jones, an occupational therapist and experienced domestic abuse practitioner.
The Occupational Therapy Department was successful in securing £10,000 from an Occupational Therapy Trust Fund, the Elizabeth Cason Trust. This was for a 6-month project within our local domestic abuse safety unit. The project was led by myself, and we harnessed the skills of an experienced domestic abuse practitioner, Kim, who newly graduated as an occupational therapist. The project was accepted as a Bevan Exemplar, providing me as a new manager with valuable support and leadership training.
The background to the project is that there has been a dramatic increase in the incidence of domestic abuse during the coronavirus pandemic. Domestic abuse is known to have an enormous impact on physical and emotional well-being and affects all aspects of daily life. The consequent cost of the economy is over £34,000 per victim per year in the loss of output, legal, social and health costs. As a student occupational therapist, I was able to use one of my practice placements to investigate occupational therapy with this client group. Good outcomes and evidence from the pilot resulted in the recommendation to pursue funding for a full-time occupational therapist for 6 months, gathering qualitative and quantitative data using standardised measures to capture the impact of occupational therapy within domestic abuse.
The aims of this project were to work at the Domestic Abuse Safety Unit base and provide upstream mental health rehabilitation and early intervention. We used a person-centred approach to help people identify goals that they wished to achieve and used engagement with important activities and roles to develop lost occupational identity, embed self-management techniques and improve well-being. We used social prescribing across community and third sector partners wherever possible during the pandemic.
We were able to influence over 500 partners, informing them of the project. We delivered all pathways, processes and paperwork. 30 service users were seen over the 6-month period, 8 of whom were signposted to manage significant risk, and 16 engaged in occupational therapy, all of whom made significant progress. We gathered qualitative and quantitative outcomes for all 16.
Each person set between 3 and 5 personalised goals, a total of 68 across the cohort. Thematic analysis revealed 8 occupational themes. People wanted to be able to cope with their symptoms, carry out an important role, establish a daily routine, manage a healthier lifestyle, find enjoyment, have and look after their home, be able to see their friends and have confidence to get out into the community. Occupational therapy interventions were aimed at overcoming the barriers to daily life and embed new habits into daily routines. A range of evidence-based interventions built self-management knowledge and skills, and these were harnessed alongside graded practice to progress towards each person's goals. Quotes from service users collated during the discharge review process evidence an improved ability to carry out each goal theme. So for ability to cope with symptoms, we heard, I don't want to die anymore. I had a panic attack, but I'm here and I'm okay. For the goal theme, being able to hold an important role, we heard, work have seen a massive change in my productivity. I got 100% in my exams. For goals about establishing a routine, and carrying out self-care, we heard, I'm walking the dog regularly. I've washed my hair. I'm eating healthier food. I've had a bath. Service users began to find enjoyment in daily tasks. Spending time with my horse is more of a joy than a hindrance. I went to my sister's and actually relaxed. Service users also reported that they had improved their ability to look after their home, tackling things that they had been putting off, paying bills, answering emails, with quotes such as, I went upstairs and cleaned my windows. Service users reported an improved ability to see friends, re-establishing lost contacts and meeting up with others, and that they had improved confidence to get out and about instead of hiding inside. Some comments were about an overall improvement in quality of life. I'm loving my new life. I'm beginning to feel more like my old self. Quantitative outcomes were measured with the Canadian Occupational Performance Measure, pre and post occupational therapy intervention. This standardised Likert scale is widely used in occupational therapy and rates ability to perform the goals identified and the service user's satisfaction with their performance. Change scores of 2 and over are considered statistically significant. We can see that all those who had completed intervention and had been discharged from occupational therapy had significant improvements with performance of their goals. Not surprisingly, those who had not completed intervention have not made as much progress yet. The same applies for the ratings of satisfaction with performance. We can see that those who have completed intervention demonstrate significant improvements in their satisfaction with their performance of their goals. Scores for people who have not completed intervention are still promising.
This project also has significant potential cost savings to the economy. The cycle of violence occurs 36 times per victim, while they exit and re-establish the relationship 7 times before ending it. The costs associated with employment, housing, health and the legal system are calculated to be over $34,000 per year for each victim of domestic abuse. For the 9 people who completed occupational therapy intervention, this equates to the saving of over £300,000. And if we add the potential saving for all full cohort of 16 people, a massive total saving of £500,000 is achieved, representing a significant return on the £10,000 from the Elizabeth Casson Trust.
There were several challenges to the project due to the COVID-19 restrictions. For example, on accessing office space, being able to network with colleagues and provide face-to-face contacts. Service users had to prioritise homeschooling over appointments. Not all people had access to technology or privacy to use it for virtual appointments. Most community activities remained closed during the pandemic, and occupational therapy were unable to provide group work, face-to-face or virtually, reducing the numbers of service users seen. In addition, we note that the project could be more prudent if support workers were used for skill practice. Without this, Kim had to deliver all of the interventions. We'd like to thank the Bevan Exemplar programme for the training and support provided. For our webpage, this showcase event, and we hope that we are considered for the Adopt and Spread programme. We have already had significant interest from the Department of Work and Pensions in supporting victims back into work, and they are seeking funding for this. Thank you for listening. Do you have any questions?
We will now have a Q&A discussion. What are the benefits of this service being provided by occupational therapists as opposed to mental health nurses?
Obviously, mental health occupational therapists hold generic mental health awareness skills and proficiency to be able to support symptom management of anxiety and depression, etc. And in our analysis of the sort of range of interventions we're offering, those are certainly in the mix. But I think the unique contribution that an occupational therapist brings when working with someone who's experienced trauma like domestic abuse is being able to understand the impact to that person in their life, in their daily life, and what is it that they are wanting to be able to do that they're now no longer able to do. Because if you can engage that person's innate volition, what interests them, what's important to them, what's meaningful then to them, and they're in their daily habituation, their routines, their roles, what hats they wear, then you've got the key to being able to implement the skills learned, say anxiety management techniques maybe, into how do I use this, and then practicing those skills in live settings through graded practice going out to the shop, practice meeting up with friends and doing those things that are important to the person. So we're really getting alongside with individuals, understanding them fully through standardized assessments that occupational therapists use using a model to get that knowledge and about that person and engage them, and it's really person-centered. And then we get right to the heart of the matter, overcome those barriers, and that's why we end up getting really good results, because it's no good being able to use mindfulness, say, for example, if you don't know how to take those steps to use it whilst you're making your way to the shop. And it's putting the two together, and that's the unique skill that occupational therapists bring.
What are your views on the importance of skilling others up?
I think when occupational therapists are working with individuals, what we're really good is doing that analysis of what's important to the person, as I was just describing. Then once we've got to the heart of the matter, and that's the uncovering and the unfolding and finding that heart, getting an agreed plan with the person is the most difficult bit. Finding something that works where somebody's starting to make progress, creating a plan of graded practice, for example. And then the practice of that actually can be handed to someone who isn't qualified. So when we work with occupational therapy technical instructors or occupational therapy assistant practitioners or support staff in any setting, really, we can guide and direct and coach practice where practice sessions are. So you're going to try this for 4 sessions. Let me come back and review how we're getting on. How do we step that up now to the next bit? How do we embed? So we're actually most prudently spent when we're working alongside where we've got direct managerial kind of clinical governance of support staff is where it works best. The difficulty sometimes where occupational therapists are harnessing support staff who may come under nursing healthcare support workers, then you can have a little bit of tension between what the nurse might be directing them to do, or other priorities like go and get some bloods, go and do one-to-one with this person to manage risk. Actually, it's the guided practice where you're coaching support staff to be able to carry out an agreed plan that's been tailored and created by an occupational therapist. That's where it works best. But we are often guiding and encouraging staff where we don't have sort of managerial authority for what they're doing. But I think the mix is important for prudence.
How are you assessing patient experience using COPM?
I'm not quite sure what the literature said, because the COPM is used globally, really, really widely used, and has been for a long time. So there probably is evidence out there if we were to look. But certainly my own experience of using it with service users in lots of different settings, satisfaction with performance is often higher than actual rated performance. And I think that's something to do with the person's acceptance of themselves, that there's a journey of, well, this is what I want to be able to do, and I'm hugely frustrated that I can't. And now I'm improving my skill and ability, and I'm getting there, and that's improving, yes. But do you know what? I'm really pleased with the improvement that I've gained. And so sometimes there's a sort of, well, this is as far as I'm going to get. So there's an understanding from the service user as, actually, things have really changed, and that's enough for me. So we quite often get a 10 on satisfaction. It's not surprising to get a 10, whereas on performance scores, the ability to do it, people don't often hit a 10 because they know that they can always get a little bit better if they try a little bit harder. So yeah, often better for satisfaction scores, if that makes sense.
How did you arrive at the figure of £34,000 per person?
Yeah, that was from a Home Office a review of the experience of domestic abuse across the population, which was conducted in 2017, March 2017 to, I think, year ending March 2017, published in 2019. So it's a little bit out of date, but it's a hugely difficult task to estimate the cost to the economy. So it's an economic cost, not a health cost. And it was, I think my memory of reading this is right, is that they do costs in anticipation. So all the sort of training and safeguarding and awareness that happens across services, those costs actually have a cost entailed. Then there's cost in terms of lost output, in terms of people no longer working that may have been working, and those really range very dramatically from something like 300,000 per person to up to 3,000 per person, up to 300,000 per person, depending on what role that person was doing within a work setting. So you might have a barrister, because domestic abuse doesn't discriminate. Anyone can be a victim of domestic abuse and find themselves in that situation. And it happens in all walks of life. So there's a huge range of potential lost output across the people who were coming to the service in 2017. And so they've had to average that out. Then there was also costs to physical and emotional harms. And we can know that the work that Kim was particularly targeting was about emotional harms. And in the paper where this was purported, that was really broken down. And even if we were to just count the cost of emotional harms, we still had a really good return on investment. It's a really difficult way of collating the amount, but this is what the Home Office came up with, and it was per victim per year, because I couldn't quite believe the cost in the first instance when we were looking into it. And that's why I think it's really important that it is an organisation like the DWP, because it is about people having sick days, not turning up for work, becoming isolated, not necessarily accessing health service. It's about living life. So yeah, that's where we got those figures from.
How has this project affected how patients use different services?
That's a really good question, and of course we don't know what would happen to those people if Kim hadn't seen them. But the usual routes of accessing support are GP, A&E, so psychiatric liaison, obviously tier 1 mental health services and tier 2 mental health services. So, you know, the cost of rocking up in the ED department, which may have happened because of a physical harm, and whether that person discloses at that point or not and gets some support through psychiatric liaison. Again, I think psychiatric liaison are really focused on crisis management for that moment then. And as I say, Kim's about to go and work in psychiatric liaison as an occupational therapist and may be able to provide some follow-on. Obviously, if somebody's rocking up to their GP, They may well be prescribed medication, which they may not need. It's about getting their life back together. And they may end up in tier 1 mental health services or even tier 2 mental health services at a much greater cost than this. But there are some people who probably wouldn't present to services in the first place, because it isn't that they are so mentally traumatized that they're requiring a mental health service, but that they're not functioning. So that they may be not working and not going out and not seeing friends, and they're not accessing support from anywhere, but they're just kind of existing. So it's this intervention has the potential for some of the cohort who maybe wouldn't get input elsewhere, to help them to do that Royal College of Occupational Therapy tagline, to live, not exist. And that's why the impact, again, hard to measure, but if somebody is taken the courage, some of our case studies had gone back into education, had gone back into work and started taking up, then we've got an impact on the kind of more social determinants of health. That, you know, if we're enabling the workforce or the population to be able to engage with daily life, then the children of those victims, those people who are coming to the service, you know, are less likely to have ACEs, more likely to have you know, an income in their house, not to experience poverty. And we know that those are determinants of health. We also know that social isolation is a determinant of health. So we're really targeting upstream at those underpinning aspects that affect somebody's overall well-being. And we may also be picking people up who could present, you know, into more secondary services down the line. Again, hard to measure, but that's what we're hoping that we've been achieving.
Could you describe the demographics of your service users?
Yeah, just out of all the 30 service users that we worked with, all 30 of them were female, 7 of which were unemployed, and that's 23 either within employment or within education. But with all 30 service users within the working age group that we worked with. And what we found is that the employment ranged across all professions. So we worked with shop workers, senior nurses, prison officers. It was really vast amount of profession, plus students that were wanting to enter college, university, or they wanted to remain within college and university. Which has a significant impact on the economy, with sick days, well-being, and manage them to remain. Some of the service users that we worked with were in employment, but they were struggling to remain in employment, so it was working with them to remain in there.